One common medication that we use in the ICU is heparin. And when we use heparin, we need ways to monitor it to make sure that it's working effectively and appropriately for our goals. Heparin in particular is a medication that we're trying to get to a therapeutic range so that we're not underdosing and we're not overdosing, mainly because we're trying to find this perfect balance of preventing clots or breaking down clots, as well as not giving too much heparin to a point where a patient can be bleeding. In the ICU, our patients are very susceptible to clots as well as bleeding, especially if they're post-surgical patients. And so finding this fine balance of a therapeutic range for heparin is very important. One of the traditional ways that we monitor heparin is with a PTT, or partial thromboplastin time. The PTT is one way to evaluate the intrinsic coagulation cascade, which starts with factor 12 and then goes to 11 and then 9 and then 8, which then activates factor 10, which then activates factor 2, and then finally factor 2 activates factor 1, which is fibrin. Heparin itself acts on antithrombin, which has a direct effect on factors 10A as well as factors 2. As you can see, there's a lot of other variables that can contribute to a PTT level outside of factors 10 and factors 2, which is why sometimes the PTT is not always the best test when trying to get to that therapeutic heparin level. Many of our patients in the ICU are in inflammatory states, and because of that, they're making more acute phase reactant than the typical patient. And acute phase reactants, such as factors 8 and fibrinogen, will impact these coagulation studies. There will be scenarios where you are giving patients increasing doses of heparin and not seeing the response of the PTT that you would expect for increasing doses of heparin, and likely this can be a result of the acute phase reactants being elevated in these patients and causing a falsely lowered PTT than what their actually coagulation status truly is. So there's another test that we can do that's called the anti-10A assay that looks specifically at 10A and heparin's relationship to it and how active heparin is with 10A. This eliminates the confounders of factors 8 and fibrinogen being elevated in our ICU patients. Now, by definition, some of these patients may be called heparin resistant because you keep going up and up on your heparin dosing without having the expected response of a therapeutic level by PTT. But when you actually check the 10A level, they may be therapeutic, and that may be why it seems like they're being resistant to the heparin. Because heparin is a largely negatively charged ion, it also gets attracted to other things. Most commonly in our ICU is ECMO circuits, and so that can also start to bind some of the heparin and also reduce its effect in the actual patient's body. How you measure heparin, whether you start off using PTTs or anti-10As, is largely going to be hospital specific. However, if you're ever in a scenario where you're giving increasing doses of heparin and you're not having much of a change with your PTT that you would expect, it would be helpful to just get an anti-10A level to make sure that you're not overdosing the heparin and to see if you're actually getting the results that you're expecting with the dose that you're giving.